It is the season of hand, foot, and mouth disease here in Chicago, so we're going to talk about that quickly for EM in 5 today. So you have a patient that comes in, 13-month-old male, sounds like he has a viral syndrome. He's got a fever, he's fussy, he's not feeding well. But mom slips in these couple little things. Been pushing the bottle away, not really wanting to put things in the mouth. It's almost as if the mouth hurts. This is where your red flags should be going off and you should start thinking about hand, foot, and mouth disease. Because when you hear about the possibility of a painful mouth, you need to make sure you look in the mouth for these oral sores, which is one of the first symptoms that'll pop up for hand, foot, and mouth disease, and you need to be thinking about Coxsackie. So hand, foot, and mouth disease tends to be in kids that are less than 5 years old, although it can happen to anyone. And it's caused mostly by Coxsackie virus. Now, that said, it's actually in the enterovirus family, and in the U.S., Coxsackie A16 is the most common, but there's actually about 6 different Coxsackie viruses, human enterovirus, and also HSV can all cause hand, foot, and mouth disease. So just think enterovirus family, most common is Coxsackie. Now, the timeline that you should be asking parents about, and maybe you'll even be seeing yourself, is that on the first day, day one, you'll be seeing fever, malaise, basically viral syndrome, might be starting to get a sore throat and not feeding that well. Within the next day or two, you'll start seeing that herpangina, or the mouth sores that are classic for hand, foot, and mouth disease. So herpangina is the mouth part of hand, foot, and mouth, and it's these painful sores in the mouth that can be vesicular and then eventually ulcerate, and they can be anywhere. They can be on the labia and the gingiva, around the teeth. They can be on the buccal mucosa on the sides, the tongue, the palate. So make sure you look anywhere. They can be quite diffuse. Now, within a day or two after that, you should start seeing the rash. It's generally going to be on the palms and soles, although it can be on the dorsal hands and feet, buttocks, or knees. And this rash lasts about 3 to 6 days. You can tell parents that it'll be clearing up after that. So just to review what it looks like on the hands, again, it can be this more vesicular lesions that are sometimes elliptical. That's kind of the classic. They can be flat though. And then the feet are going to be largely the same. So there's a couple of examples. And then, like I said, it can also be on the buttocks or other parts of the extremities, the knees, the elbows, although it tends to be on the palms and the soles first. So as far as complications, mostly this is a self-resolving disease, just like most viral syndromes. One thing you really have to look out for, just like in most viral illnesses, is dehydration. And this is especially important in hand, foot, and mouth because you have not only a fussy kid who doesn't want to eat and who has fevers, but they also have these terrible mouth sores. So make sure you're evaluating them for dehydration in the ER. Look for dry mucous membranes, no tears, a sunken fontanelle, or decreased skin turgor. Other complications that are not quite as common are aseptic meningitis and encephalitis. And there's actually a couple cases, interestingly enough, that a couple weeks after the illness, that they'll get nail loss. Kind of interesting. So this is spread pretty much any way you can think of. So it's in the respiratory tract, so saliva, coughing, sneezing, but it's also in the stool and feces as well. So make sure that you're telling parents to definitely have your kids wash their hands so they're not passing it around the family, because this can be direct contact, it can be airborne, or it can be on fomites. A lot of easy ways to spread hand, foot, and mouth disease. So treatment is mostly going to be supportive care. Make sure, again, assess them for hydration. See if you can do PO hydration or if you actually need to start an IV on these kids in the ER. Talk to parents about appropriate doses of antipyretics and pain control. That's something that we miss a lot, and tell them to redose it frequently as needed. Lastly, there's this little bit of controversial thing called magic mouthwash. And it sounds great, right? Magic mouthwash. But there's a little bit of controversy to it. First, let's explain how to mix it up. So there's a bunch of different recipes for this. We use it a lot actually in cancer patients who have mucositis. This is probably the most common recipe, so to speak, for it. It's going to be 1 part each of viscous lidocaine, 2% Maalox, and diphenhydramine elixir or solution. And you mix those up. The probably most common variation is not to include the viscous lidocaine. So how you apply it is, in the younger kids, you can do a swab directly to the mouth sores, or if they're a little bit older, you can do a swish and spit. They're not supposed to swallow this, so emphasize not to swallow this. Here's the considerations. This is why it's a little controversial. Number 1, it's pretty much anecdotal. Some people love it. They think it works well. Parents like it. They said it makes their kids much more comfortable and able to actually take PO fluids, which is the whole reason we're giving this, right? So that the kids don't become dehydrated. However, there have been studies, including in the Annals of Emergency Medicine, saying that it's really not effective and it doesn't increase the patient's ability to take in POs. This is the one thing against it. Why wouldn't we give it? Why wouldn't we just try it? Because there's a potential for toxicity both with the lidocaine and the diphenhydramine. So here's my thought on this. If you're going to prescribe it, if the parents feel like it's very helpful, if you have a ton of oral sores and you're having a hard time keeping them hydrated, I would prescribe, first of all, a very small amount. So just prescribe just enough for the first day or two. And second, don't even tell them to do a swish and spit if you don't think that the parents can and the kids can really handle that. Just tell them to swab it on the oral sores. That should take away pretty much any potential for toxicity and hopefully provide a little bit of relief to the patient. So 3 to remember for hand, foot, and mouth disease. Anytime you think about a viral syndrome with painful mouth, think about hand, foot, and mouth, and it's most commonly caused by Coxsackie. Your classic for this is going to be fever plus Herpangina, which is the mouth sores, and then palm and soles. Mostly we're doing supportive care. Make sure you watch out for dehydration. This is going to be the most dangerous thing to your patient. And consider using magic mouthwash in certain kids. Here's the references, and thanks for joining us on EM in 5.